integrates the best available research, the music therapist's expertise, and the needs, values, and preferences of the individual served. Techniques developed emphasize research rigor, professional requirements of practice, and the observation of set standards and protocols. Music therapy is also immersive and relational. What this means is it involves different levels of participation and emphasizes the need to build a relationship of trust to develop what we call a therapeutic alliance between the therapist and the client or patient. It is also multisensory. It engages all senses and caters to all levels of human functioning. It is adaptive and malleable. Activities are designed to fit a variety of settings and circumstances, catering to different severity levels, and is adaptable to different medical as well as healthcare settings and contexts. It is inclusive. It caters to all, including those with special needs, and this includes acquired disability for some patients who end up in hospital, as well as their families. It also includes individuals from diverse backgrounds, and it always operates within a culturally sensitive framework. This is something that I know is a strength of ISCM, the salutogenic approach. So music therapy incorporates proactive approaches to health and well-being, and we'll be going more detail into this in subsequent slides. Including music as an option and solution towards healthcare problems is often more user-friendly, appealing, and attractive to service users, as most people associate music with entertainment and recreation, and not treatment. So it is perceived as non-threatening, non-invasive, and less stigmatizing. You can see from the right-hand side, I just summarized that music therapy involves the strategic and scientific uses of music to stimulate, support, and strengthen human functioning. It also shapes our ability to respond to others as well as the environment. And this includes the hospital environment. So my presentation is basically going to be broken up into 3 sections. And I will be integrating elements of culturally responsive implementation, evidence-based practice. But my main focus in the beginning of this presentation will be on the biopsychosocial model and how it is applied in a music therapy context. I hope that some of the examples coming from Malaysia will also draw parallels with what you experience in India. And I look forward to your questions later. So let's get into the biopsychosocial model. We know that the biopsychosocial model is a theory of illness and healing formulated by George Engel, with the fundamental assumption that health and illness are consequences of the interplay between these 3 factors you see on the right: biological, psychological, and social factors. But these are often overlooked in medical treatment. And by these, I mean the social and psychological factors. So the biopsychological model is both a philosophy of clinical care and practical clinical guide. The biopsychosocial model incorporates these components into patient care and emphasizes a holistic approach to patient care. Psychological and social factors explain more variance in quality of life, and it is better incorporated into clinical care as recommended. So we are looking towards how social workers, psychologists, music therapists can complement the hospital environment to provide the psychosocial support needed by patients as well as their families to help facilitate the process and contribute towards holistic healing. Philosophically, the biopsychosocial model is a way of understanding how suffering, disease, and illness are affected by multiple levels of organization, from the societal to the molecular. Clinically, it is a way of understanding that the patient's subjective experience is an essential contributor to accurate diagnosis, health outcomes, and human care. It follows that health and disease are best understood in terms of a combination of biological, psychological, and social factors, rather than purely in biological terms. I'm sure many of you in the audience will agree with me. And this is in contrast to the biomedical model of medicine that suggests that every disease process can be solely explained in terms of a deviation from normal function, such as a physiological process, infection, genes, developmental abnormalities, or injuries. In addition to behavioral medicine, The model is used in fields, not just in medicine, but also in nursing, health psychology, sociology, and particularly more in specialty fields such as psychiatry, family therapy, clinical social work, clinical psychology, and increasingly so in medical music therapy. The biopsychosocial model consists of the 4 Ps, as you can see from the diagram on the right. And they represent each of the biological, psychological, and social factors. Predisposing factors, which you will see right next to each bubble, are areas of vulnerability that increase the risk for the presenting problem. Examples include genetic, family history, predisposition for mental illness, or prenatal exposure to alcohol. The second P factor, precipitating factors, are typically thought of as stresses or other events that could be positive or negative, that may be precipitants of the symptoms. Examples include conflicts about identity, relationship conflicts, or transitions. The third P factor, perpetuating factors, are any condition in the patient, family, community, or larger systems that exacerbate rather than solve the problem. Examples include unaddressed relationship conflicts, lack of education, financial stresses, and occupational stress, or even lack of employment. And the fourth P, protective factors, include the patient's own areas of competency, skills, talents, interests, and supportive elements. Protective factors counteract the predisposing, precipitating, and perpetuating factors. So what you will notice is the combination of these 4 factors contribute towards complications in patient treatment. And I will go a little bit more in depth later as to how we use music therapy to address these factors. But let's look at this slide. I'm sure that many of us are already familiar with the biomedical side of treatment. But Engel, who was the originator of the modern biopsychosocial model, found that illness is more than just a biochemical alteration, and it does not directly translate into an illness. There are other causal factors, and psychological alterations or shift may manifest as illness or forms of suffering that contribute towards health problems. So we mentioned just now the importance of understanding or trying to grasp the patient's overall illness experience. And so the presence of a biological derangement alone does not shed light on the meaning of the symptom to the patient. So we're talking about patient experience, including their subjective experience. And psychological variables are more important determinants of susceptibility, severity, and cause of illness that had been previously appreciated by those who maintain a biomedical view of illness. So the success of most biological treatments is influenced by psychosocial factors, for example, the placebo effect. And the patient-clinician relationship influences medical outcomes, even if it is only because of its influence on adherence to a chosen treatment, patient compliance. You will find that there will be many mentions later on about the importance of patient cooperation, patient compliance. This is a whole area that looks at the outcomes of treatment. We are administering treatment to patients, and we hope that they are receptive to the techniques, to whatever recommendations are made by the medical team. However, the reality, as we know, is that patients don't always follow through. And what the biopsychosocial model reveals is that there are often mediating factors that prevent patients from being able to fully express themselves in a treatment context in order to fully embrace recommendations for treatment. So understanding the main effects of various factors is often difficult. We talk about the complexities of understanding health. Real-world phenomenon very rarely function as a point A to point C cause and effect situation, as you can see from the top diagram, where we can easily identify all the predisposing, precipitating, perpetuating, and protective factors leading to why each patient ends up in hospital. In between point A and point C, there are often complex factors contributing towards a patient's overall illness experience. That's the diagram below. The truth lies in the interaction of these factors within and across levels. So these interactions between factors are simply represented in this diagram with the rectangle marked B, which we consider as the mediating factor. Mediating factors like B can change the nature of the causal relationship between A and C, creating more complex pathways. In other words, this is more a mirror of reality. As you can see, it is far more messy and complicated than the simple cause and effect diagram which I generated on the previous slide. So this diagram is actually taken from a very famous study by Dr. Ken Scher from the University of Missouri, a well-known expert on alcohol addiction, who used the biopsychosocial model to create major breakthroughs in the treatment of alcoholism. From this diagram, we will be able to identify the range of predisposing, precipitating, perpetuating, and protective factors. At a glance, you can see that there are a huge range of mediating and moderating factors, including genetic predispositions, self-destructive behaviors, societal patterns that unfortunately encourage unhealthy consumption of alcoholic beverages. So non-compliance is a major challenge in treatment, and many of the mediating factors that we can see from this complex diagram represent known challenges in treating alcoholism. Through application of the biopsychosocial model, we can formulate our understanding of the patient as more than just a diagnostic label, and better understand the origins and causes of patient symptoms and use that information as a guide to both treatment and prognosis. The extant research shows that in trying to deal with any patient in hospital, there are often mediating factors that are psychosocial in nature and contribute towards patients' non-compliance, including lack of participation, depression, denial, and resistance towards treatment. Recognizing the mediating psychological and social factors that are preventing the patient from fully cooperating with the treatment is critical to encourage patients to fully participate in treatment and enhance treatment effectiveness. In all honesty, that is one of the main reasons the government hospitals in Kuala Lumpur, Malaysia, where I live, have asked me to intervene with medical music therapy support. Patient depression, resistance to treatment, and non-compliance are also major barriers to treatment in Malaysia. The biopsychosocial model and case formulation in psychiatry is an example of ways of understanding a patient as more than a diagnostic label. Hypotheses are generated about the origins and causes of a patient's symptoms. The most common and clinically practical way to formulate it is through the biopsychosocial approach. Biopsychosocial formulation combines biological, psychological, social factors to understand a patient and uses this to both guide treatment and prognosis. Your formulation of a patient evolves and changes as you collect more information. Formulation is something like cooking, and there is no right or wrong, but it gets better over time with increasing clinical experience and more accurate information. So diagnosis is not the same as formulation in mental health. When there is a group of consistent symptoms seen in a population, these symptoms can be categorized into a distinct entity called a diagnosis. And this is what the DSM-5 Diagnostic Statistical Manual does. For example, we diagnose someone with a major depressive episode while they're in hospital if they meet 5 out of the 9 symptoms criteria. However, formulation tells us how the person became depressed as a result of their genetics, personality, psychological factors, biological factors, social circumstances, including childhood adverse events and social determinants of health and their environment. More recently, in the research, we have been talking a lot more about trauma and music therapy and how much childhood adverse events, or what we call adverse childhood events, ACEs, often contribute as a form of emotional baggage into the patient's ability to respond to treatment. And so we can't treat the patient effectively if there are ACEs present in their lives that are hindering their ability to respond. So what are we effectively formulating when we go through this process? Each time you formulate, always ask yourself, what exactly am I doing? What are we trying to understand about the patient? Usually, it is their current symptoms of presentation, for example, the history of the presenting illness or HPI, but it's not always going to be the case. In some cases, there may not be any current symptoms to formulate. You may instead want to formulate the most recent episode of illness, the lifelong psychiatric diagnosis, or perhaps even the patient's chronic thoughts of suicide, just to name a few examples. I've actually been in situations in the hospital, both in the US and Malaysia, where the patient had suicidal ideation, and it just completely changes the whole dynamic of the treatment process. So we are probably already formulating, but just don't know it. Like most things in medical treatment, there are multifactorial causes of diseases, illnesses, and disorders. For example, if you're treating a patient that has type 2 diabetes, diabetes does not develop because of a single pathophysiological cause. The patient may have a strong family history of the disease, a sedentary job, environmental exposures, and/or a nutritionally poor diet. And these factors all combine to cause the person to develop diabetes. Understanding how each factor contributes to the disease can better guide treatment decisions. In the case of mental health, formulation appears more complicated because human behavior and the brain itself is extraordinarily complex, and getting responses from patients so that we can know the facts is not always easy due to their inhibitions and also cultural stigma. In situations like this, music therapy techniques such as song lyric analysis can act as a non-invasive way to draw out responses from the patients so we can obtain the information needed for proper formulation. You can see on the right-hand side where the box is highlighted in green, I'm hinting at the fact that music therapy applications can be used at this particular stage to support case formulation. Understanding and respecting patients' values, preferences, and expressed needs is the foundation of patient-centered care. So this is an example of song lyric analysis to support formulation. The main objective of using song lyric analysis as a music therapy technique is to support the gentle easing into conversation with the patient about their current situation. It is more indirect, less invasive to ask the patient questions surrounding the context of a song. And you can use the responses that the patient projects into the song to gather information about the range of biological, psychological, social factors affecting the patient and understanding the patient. We can then use this information to create a more holistic formulation to guide both treatment and prognosis. So what do we mean by using the song to draw out responses? I have given you a very simple series of steps. And these are some of the questions we may use in song lyric analysis as music therapists to draw a patient's response. So at first, we will present a selection of songs from the patient's preferred genre. And this is because the music therapy research shows that the patient always responds best to musical preference. So if you know and you're able to discover what kind of music that the patient likes, if there are particular Bollywood films or particular Indian classical Carnatic music that you know really puts the patient in a good mood, and in past sessions you have found that they seem to respond to that kind of music more powerfully than others, that could hint at a probable music preference. But using that as a guide, we present a menu of choices to the patient with themes that you believe mirrors the patient's feelings or their current struggles. And then you allow the patient to choose which song they would prefer to listen to, and you play the song. Now, this element of giving the patient choice, especially when they are in a hospital context, is very important because we are giving them a sense of control, a sense of personal agency, which helps to release some of the tension and frustration that patients often encounter in hospital settings. We have to be honest that, often when we are admitted to the hospital, we have to follow regulations. It's important, right? And many of these rules, regulations, instructions are meant for our care and safety. But the fact of the matter is, especially if you're dealing with patients who are taken out of their comfort zone, their home, their community, and then they are admitted into hospital, most patients don't enjoy staying in a hospital. They are not really there because they want to be. It's not like booking a holiday and going into a hotel, right? They are in a hospital because on many levels, they may have serious health concerns that need immediate attention. And so there's also an underlying element of anxiety and being in a situation where you don't have much control over the food that you eat, the bed that you sleep in, whether you have a roommate or not. Sometimes all these factors are taking away the personal agency and the independence and the decision-making abilities of patients. So in situations like this, I know it sounds simple, but you're literally returning that sense of self, that sense of control back to the patient by allowing them to choose what kind of music they want to listen to. And I've seen how patients immediately seem more relaxed because they feel in control of the situation. And of course, we know in this context, it's perfectly safe to ask a patient to just choose which song they would prefer to listen to. But you as a therapist have already forethought and screened through the songs to select the songs that you think have song lyrics, messages, themes that will resonate with the patient's current situation. So you then gently ask a series of general probing questions about the song lyrics, beginning with general ideas. So you don't go straight away and ask, the most critical and immediate questions about their illness condition. You start by circumventing. You can ask general questions like, so what do you think this song is about? Or how do you like this song? Or why did you choose this song? These are more general, more non-invasive questions. And then the patient starts to tell you the reasons why they selected the song or what they think the song is about. And what you're listening for is you're not just taking the answers at face value. But very often, if I were to ask a group like ours, the audience today, after we've heard a song, what do you think about the song? What do you think the song is about? We're probably going to get a variety of responses, right? Each one of you will listen to the song, the same set of lyrics, but you will probably derive something different from the song in terms of interpretation. And in psychological terms, what that means is you are projecting, you are mirroring whatever internal feelings, whatever experiences you're having, and your thought processes are bleeding through in a way that actually reveal more of your condition. So as therapists, we are trained to listen and we are trained to be able to read between the lines. So if you're telling me something about the song that on the surface looks like you're just talking about the song, you're actually also potentially revealing something about yourself in this situation. And so we take those cues and then we probe deeper. We go into, things like how does the song make you feel? And very often I find in therapeutic conversation like this, it starts to break down the defenses. It starts to lower the barriers with patients. I've used song lyric analysis a lot for many, many reasons. And I found that over the course of the conversation, patients actually start to build trust. They start to relax and they start to actually reveal more and more of their situation. And if you're successful in breaking the ice, the patient may actually get to a point where they just want to talk about their situation because they've already developed that rapport with you as a therapist. They've had this conversation around the song. And the beauty of it is anytime they reveal something that may be perhaps a little bit personal, and in that moment, the patient feels a bit exposed, they can always retreat behind the song. And what that means is they can go back to talking about something about the song, referring back to the song lyrics. So you are creating a safe space through the song lyric analysis process, using music as that environment to help the patient to process the experience of being in the hospital, start to confront some of the feelings and the emotional barriers they may be experiencing. Maybe the patient is feeling really anxious, but just doesn't know how to express that anxiety. Maybe the patient is in denial. And so whatever is bubbling under the surface of their experience will more likely come out through their projection as you're talking about the song. So the song functions as a safety net. The song is a hiding place, but it is most of all a safe place for the patient to process what they're going through while being in a hospital and to reveal that information that you need to help you to formulate a better idea of what the patient's experience is in hospital and what could potentially be the factors that are mediating factors that are inhibiting treatment or causing there to be some level of dysfunctional behavior that prevents the patient from fully embracing treatment. So I mentioned just now that the psychosocial factors are actually probably the main reason why I'm called to go into hospitals to work with patients. And I get told all the time from doctors, their main frustration is that patients often feel that they're there against their will. It's because of the illness, they got a stroke, they experienced a traumatic brain injury, something happened in terms of their biological illness that caused them to have to be in that environment. But on the other hand, they are also struggling to have an outlet to process the experience. And very often, if you have a stroke, if you have a chronic illness, it may happen quite suddenly. And so patients are also in shock. And so all these range of emotions, feelings, psychosocial factors are swirling in their mind and affecting their ability to respond. They are medicated, so sometimes there are side effects of medication that cause them to also be partly sedated, and they are in pain and discomfort. And very often they are worrying about the future. They don't know what's going to happen next. They don't know whether they're going to be ending up in hospital for longer term or whether they can be dismissed and discharged sooner rather than later. There are so many anxieties and concerns. And if the family is not prepared to deal with the illness, then all these concerns just escalate. So when we are using these probing questions to try to draw out the factors to understand what is the patient's illness experience, we are potentially giving the patient a chance to tell us what is happening in their lives and what is going to also help them to be successful in treatment. So when you go into more details about the song, you might ask, things about particular words or phrases that jump out at them and that resonate with you. And you're also asking clarifying questions. So you notice all these questions are open-ended, right? They are not yes or no questions. You're actually inviting the patient to offer more information. And if you ask a close-ended question like yes or no, you don't get very far. And it's not really helping the patient to process. So you are purposefully and intentionally asking questions that will enable the patient to start talking and slowly start unlocking their feelings, again, within that safe space, and to start to process, because as they're talking to you, as they're describing their experience, as they're revealing more and more what they're feeling and thinking, they are actually clarifying and understanding themselves better in that context. So there's a whole range of techniques you can be trained in with song lyric analysis. Sometimes you do songwriting as well as a continuum. But I just wanted to give you a glimpse of what we do with music therapy to address those particular needs. And I paired it specifically with formulation because I see that as a direct way that you can actually immediately benefit the patient. And of course, through that information, it also helps you to arrive at a more accurate diagnosis. So this actually takes a slightly different slant. We're now looking at disability. And what I experienced when I was working in government hospitals in Malaysia is very often we don't necessarily think about patients in the hospital being disabled. But then again, you end up in situations where the patient may have to have surgery, amputation. They may just have had a stroke. I mentioned stroke just now. I work with a lot of stroke patients. And because of the stroke, they end up with hemiparalysis, and they may end up with limbs that are so weak that they are literally disabled. And it's a very traumatic experience for the patient. So here we are talking about patients who, whether they intend or not, end up acquiring a disability because of their illness and their sickness. Or even patients that end up in hospital with congenital disability. You can have either one. There are many patients I've seen in the government hospital in KL who are admitted for stroke, but they all end up having amputations. So I just want to give you the heads up because later on, as you see slides and I share some pictures from those hospital visits, you will see some patients who are in wheelchair and some of them literally don't have their lower leg because they actually had to be amputated because they were also diabetic. And unfortunately, gangrene already set in. So with patients in a hospital who may be experiencing disability, we can adapt the biopsychosocial model as a model of functioning disability and health to help us to identify body functions and structures, which also means psychological factors and their impairment level, their perception about the impairment. I remember doing a music therapy activity where we had patients who were paralyzed on one side of the body. And so we use music and a scarf activity to help them to accept the rejected limb. Because we know from the research that even if patients have become weaker on one side of the body, it doesn't mean that we just leave that limb alone. We still have to go for physiotherapy. We still have to make sure we exercise the limb that is weak to prevent further neglect. And that is a major concern. Because in hospitals, sometimes patients give up, and we understand it's difficult. And sometimes the rehab process itself can be very, very grueling, very demanding. I've had cases, this was in the States, where you have patients who had hip replacement surgery, and this sweet old lady in her 80s, what she did was, before she was due to go for her physiotherapy, occupational therapy session, she went and locked herself in the bathroom because she couldn't bear the thought of going for the therapy because it involved pain. And it was really, really, I think for those of you who are familiar, if you're recovering from a hip replacement surgery, kneecap replacement surgery, it's really, really painful, as with the recovery process. So it's also understandable why sometimes patients are very reluctant to participate in therapy. So music therapy in that situation in US was called in to try to see whether we could get her to unlock the bathroom door, and then to get to understand what was it that she was so fearful of, and then how can we help her to proceed with the physiotherapy, because we know that she needs the physiotherapy. So very often we work as doctors' allies, and we work as patient advocates as well, to build a bridge of understanding and help the patients who have lost physical functioning and struggling with self-acceptance, denial, experiencing grief or loss of the absent limbs and functioning. And sometimes we know, we've heard of the phenomenon called phantom limbs, right? So if they have had an amputation, and so the lower part of their left leg is no more there, but they suddenly feel an itch on their calf on the left leg, but the limb is actually no more there. So, all these things have techniques, of course, to deal with it, but it's psychologically traumatic for the patient and often the families as well. So we initiate activities that the person can participate in, as well as their ability or limitations to participate. This is actually a way that we use music to assess. So we are using music as much as we introduce music, and then we observe how they perform, how they are able to respond in the music activities. And that gives us a chance to gauge and to confirm where there are specific areas of weakness or rehabilitation need. Usually what I do is I work very, very closely with the rehab team. So I'll go and speak to the physiotherapists, the occupational therapists, speech therapists. I work with the medical doctors who are in charge of that particular patient case. And I also try to formulate goals in music therapy that actually complement their rehab treatment goals. So it's actually working in tandem. And I'm trying to enhance the patient's ability, not just to respond within the music therapy setting, but I'm also trying to develop their confidence and to help them to understand, see, this movement that you're doing here, this is very similar to what your physiotherapist is asking you to do. This is why we're doing it. And when we do it with music, see, I'm trying to encourage the patient to see how much further they can go. So sometimes what I work with using music is to increase intensity, frequency, because we know these things matter in the course of their recovery. And when they confront it in that safe music space, fun and engaging music environment, sometimes they don't even realize that they're working on their rehab goals. So I make it a point to point it out to them so they start to see the connection. But more importantly, they start to develop that sense of self-confidence and motivation, that if I can do it here, then there's no reason why I can't do it when I'm in the physio session and I'm doing similar exercises. So that connection is absolutely vital to also develop. The other thing that we do using this model is to assess the environment itself, physical, social, attitudes, which affects this experience, including the strengths or barriers in the environment. There were times when we are working in wards that are slightly open, so you have outside noise from the environment. I remember once I used to go on a regular Friday session to this ward where they would put about 40 patients, which is a lot. And I would say, well, can we break the groups up into smaller groups, and then we would have just 20 at a time. But then inevitably, once they hear music, then more and more patients will be wheeled in, and before you knew it, the group would grow. And you have no heart to turn away the patients, because they need the music, they need the support. So in whatever way we could accommodate, we would try to include them. But we did try to separate into levels of severity, because we want to make sure that the music therapy is administered in a way that directly benefits the patient. So if there's too many of mixed levels, it gets harder to make sure that every patient is able to benefit from that process. So environmental barriers, including noise in the environment, there's a lot of research. In fact, now there's an upcoming area called environmental music therapy. And later on, when we go into subsequent slides, you will see something which I introduced as part of a health musicking model. And it talks about soundscapes. And it's all about sound in the environment, noises that interfere with a patient's ability to respond. And there are research studies that actually have been done that show that when patients are in environments that have a lot of alarms, beeps, if you're in ICU, you can't help it, right? Those alarms are important to alert the nurses that a patient's vital signs are in danger of dropping below a certain safe point. So you need to have those alarms. But sometimes the patients can feel a bit traumatized by having too much environmental noise that actually affects their mental health. So paying attention to environmental factors, attitudinal factors, you will see later on when we talk about inclusion, that's an example of environmental attitudes. All these can also affect the patient's experiences and also represent strengths and barriers to treatment. Personal factors, such as the person's lifestyle, gender, age, and so on, are also important, although they may not seem to be part of the primary health condition. One of the things I try to prepare patients for through the music therapy sessions is to anticipate what's going to happen when they are discharged. We know that patients want to go home as soon as possible. And so if we can help them to start to anticipate what do they need to change in their lifestyle, what are the things that they need to do differently when they go back so they can stay healthy? Because we don't want them to have a recurrent stroke, right? If they have already experienced a minor stroke, there's always a danger that if they get a recurrent stroke, it's going to be far more severe and the patient may end up as a vegetable. So we also use music and conversation, a variety of different music therapy techniques to engage them with the reality of their situation and to look towards what personal factors perhaps they need to address, they need to look into to change behavior so that they can maintain their state of health for as long as possible and avoid more medical complications. So I'm going to take a moment to talk about inclusion because I'm so sorry, let me just go back 1 minute. I mentioned at the bottom here of this green box, music therapy can be used in group activities to foster inclusion, to spur motivation for rehabilitation, as well as promote self-acceptance. And this is really important because we found that there are times when group dynamics, I'm trained to work individually, but also in groups. And I found that you can use the group process when you have a group of patients together, you actually can create some form of a support group among the patients. So you are actively mobilizing the social aspects of the group to get them to build friendships so that they feel alone. Because when we are there as music therapists, we are only there for a certain limited time, right? I'm there for 1.5 hour, 2 hour session. I cannot be there too long because it will overtire the patient. So I try to keep it to a certain limit. And then after that, I go back to UPM with my students. And so they're left on their own and they have to cope. So given that full awareness that we are only there to attend to them for a limited amount of time, what helps if I can use the music therapy process to also help to patients. And who else knows better about what a patient is going through than another patient that may be also afflicted by the same condition? And so if you have one stroke patient who is struggling, but he gets to find comfort and support in another stroke patient and maybe the family members who are there, I always make it a point when I'm in these hospital settings. If there are family members present, I bring them into the therapy session because what you want is to build an ally and you want to help the family members to also understand how important their support is in treatment and to help the patient get better. So sometimes we break resistance from family members. I remember there was one particular case where there was this lady, she's not that old, she was only in her 40s, but by some miracle, she had had 3 strokes, but she still was able to sit in a wheelchair. She had very slurred speech, but given she had 3 minor strokes, it was very fortunate that she was not bedridden, but she was very, very depressed, very demotivated. And I remember the first time I was in the hospital and the doctor was asking me, can you try to do something with music? And I was trying to elicit her cooperation. She was polite, but not really interested to be engaged in anything. So what I noticed was her little daughter was there. And so what I decided to do was I encouraged the little girl. You know, poor little girl, right? She's stuck in the ward. Might as well give her something to do, and music is fun. So I got her to be involved with the mother. But once the mother saw that the daughter was enjoying herself and the daughter was actually receiving a lot of acknowledgement, a lot of acceptance from the group, you could see that the mother slowly start to lower her own barriers and she started to respond. And so I was using that dynamic of a family member being present, knowing that the family member is more likely to be more receptive, and then using that as a means to slowly reach out to the patient. And so eventually the patient was not only engaged, but by the time that we were seeing this patient several times, and later on we found out that on the last session she was going to be there, it was the daughter's birthday. So guess what? That became the perfect excuse. We sang her happy birthday, we had balloons with us because we use it for music therapy activity, but it became a celebration. So I'm a mother, and it means a lot to me to be able to celebrate my child's birthday. But can you imagine how that mother was feeling? She's in hospital, she is wheelchair bound, she has all these residual side effects of having 3 strokes, and she's limited in her ability to do anything for the daughter's birthday. I can't imagine the level of frustration. But lo and behold, we were actually celebrating the daughter's birthday with her in the hospital. And we made it such a big deal because there was more than 40 over people. And even though we didn't have any birthday cake, but the medical doctors there and the staff were wonderful. And, they tried to come over, wish her. So the little girl felt so special. And it made a world of difference for the mother. So before she left, her husband actually came forward and said, "Thank you so much for doing that, because you don't know what it means for my wife." So, things like that are one of the joys of being able to bring music into the hospital, because you never know what the patient's struggle is. So I was actually creating an activity using the group dynamics to promote inclusion, to promote acceptance. So nobody feels different. Nobody feels that because they have a disability, because they have an injury and they are recovering from illness, that they are lesser than. And inclusion itself is extremely important as a principle, because it actually gives us a chance to identify and then seek ways to actively remove barriers which are preventing people with disability in the hospital. I mentioned just now acquired disability or even congenital disability, which they're born with, as well as in any other medical treatment settings, to help them to adjust to their condition by creating an empathetic, supportive environment that sees the person instead of the disease. So one thing that's really beautiful about musical activities in a group is that you can focus on the music product. You can focus on the music making. We are not there to train a professional choir, but we are there to engage people in this positive music making experience in a way that just momentarily helps them to forget their disability and their illness, but focus on enjoying the music process. And all the time, I'm embedding their rehab goals. It's just they may or may not realize it. So if you're doing singing, we're working on certain speech communication skills. We are working on increasing their range, their volume, all things that are functional in their everyday speech. So creating musical experience in which everyone, regardless of level of ability or disability, can reap the optimal benefits from that musical experience, build positive relationships with caregivers, medical personnel, as well as therapists. Sometimes what we've done, this happened a lot in the States, because you can imagine burnout among the medical staff is quite a common experience, especially now, post-pandemic. We know that our doctors, our nurses, technicians in hospitals, everybody has been working so hard because of the pandemic, and many of them are tired. So they also need that support as much as the patients need support. And so what we used to do is find ways to use music as a way to get the hospital workers to also participate and be a part of that experience. And in doing so, you're actually helping to improve their relationship with the patients. So instead of the patients seeing the nurse who is always there to give them their bath or give them medicine as someone who is a stranger who is forced to do this, if they are able to build their relationship and their positive bonding with that particular staff in a way that helps them to start to develop a genuine relationship, it just makes the course of the hospital stay so much easier, because they've actually overcome certain personal barriers and develop trust in the process. And sometimes I get them to use musical play to interact, so they start to see a different side of each other, and all these things lowers defenses. And I mentioned just now the importance of providing hospital workers with musical support for relaxation and also respite. They need to also have a break, mental break, psychological break. So hospital environments for patients with disabilities range from complete denial of formal educational services to equal participation. So here we are trying to provide opportunities using musical engagement to transcend the actual environment. So the hospital may have limitations which they can't really help, but you can do something through music to actually transform the experience of being in a hospital. So it's something that is far more equitable and allows all patients to feel accepted and supported. So these are examples of some of the things I mentioned just now. You will notice from the pictures that this is actually a combination of my UPM team. The green ones are the students. The red ones are my seniors from music therapy work who are considered well elderly. And what happened was we started out with these UPM students who I trained to go into therapy. This girl here on the right-hand picture who is standing and looking towards the patients with her hands clasped together. She just completed her master's in medical music therapy in Florida State University. I'm so happy for her. And so these were students who we trained and then brought into the hospitals. And there's actually my daughter in the picture as well. You know, if you go there on Saturdays, I can bring her along, because sometimes what happens is, even though this particular ward is a neuro ward and it's stroke patients and traumatic brain injury patients, sometimes what happens is the doctors and the nurses actually bring in cerebral palsy children and children with multiple sclerosis, because they have a unit for that. And so I found that, you know, having another child there, and that's how I brought my daughter, was very comforting for the children, because they don't feel alone. Because otherwise it's a room full of adults and then they are just 3 or 4 little children here and they feel very self-conscious. So I actually brought my daughter, I trained my daughter to be able to respond, just to build friendships with them and to encourage the children. And I found it made a lot of difference. So that's why she's there. But you can see that there is a lot of potential for psychosocial support and ways that we are trying to foster not just musical engagement, but a level of engagement that is intense enough to actually spur and support their rehab treatment goals. I really, really love this team of students, both old and young. They are such a committed team, and they used to come all the way across the state, you know, take bus, take public transport, sometimes travel just for 2 hours, just to be able to come to the hospital. So I really, really appreciate it. So this is another more in-depth look at what was happening in some of the activities. So here you can see that this lady is in a wheelchair. In fact, what was very, very important about this activity is we're encouraging them to expand their range of motion. That's where you see the balloons, and balloons are very light. They're very colorful, they're floaty. There's something about a balloon that when you look at a balloon, you think about, you know, happy things, positive things. And it's so light that even people who have very severe and profound neglect can reach out and just gently touch the balloon and the balloon will move. So it gives a chance for everyone to participate regardless of their level of ability or disability. And you can see from the middle row, the top picture, I have a student in green. She's now doing her master's in music therapy in University of Melbourne. And she was an undergraduate then. She actually is reaching out with the balloon, and her balloon is smaller because we're trying to adjust the weight of the balloon. So the bigger balloons are a little harder to handle, but you know, if you blow the balloons up and they're slightly smaller, just slightly easier to handle. And you can see this gentleman who's seated in the wheelchair. He's struggling with some level of rigidity and spasticity in his hands, but he's still reaching out. You can still see from his body language, he's still trying to participate. So the students are trained to respond to each of the patients. And the reason why I bring such a big team is because then we have more of the UPM team to go around to spread out across the group. So we may have like 1 UPM team member to 2 patients, so they can get more personal support. And if there are family members there, we always encourage them to participate. And you can see from the different activities, you know, whether it's balloons, whether it's giant carts, we are encouraging them to participate in multiple ways. And there's a lot of cognitive stimulative activities, music and movement activities, memory activities, recall, because these are stroke patients and you need to be stimulated in that way. A range of different activities. Every single thing we do is geared towards supporting their medical treatment rehab goals. What I like about this picture on the top hand right corner is you see this lady who's the wife of the gentleman in the wheelchair. He's actually quite depressed and he was not willing to participate, but she was actually helping him. But in the process, they got to work together. And that kind of behavior and that kind of support spills over beyond just the music therapy session itself. And one thing that you will know from music therapy is that it's really important for us to teach for transfer, which means we're not just interested in seeing what can music do to spur and encourage psychosocial support or any other rehab goal in that music therapy session. We are looking for transfer effects beyond the immediate session. So everything that we do is also designed to encourage the kind of behavior and level of engagement that will actually continue to benefit the patient beyond the immediate music therapy session. That's very, very important. So I mentioned just now, you know, as part of inclusion, we also are looking at ways to break stigma in society. And in Malaysia, we have our own national social policies that are in place to help to protect the rights of citizens, including those with disabilities. But I found it very interesting that one of the 15 areas that was actually written in this policy included rehabilitation. Of course, rehabilitation comes in many forms, but you can see that I'm sure in India, you will have your own national policies that also have elements of inclusion. So I hope that my sharing of the Malaysian scenario and what we do through music therapy in Malaysian hospitals also resonates with you in ways that you can draw comparisons with India. So this is the actual event that we put together under UPM. Before the pandemic, we had the luxury of having these large groups. And so you can see the top right-hand corner here, you have 2 UPM students wheeling 2 patients. They're actually Parkinson's patients. We have a network here of Parkinson's patients that we work with. We've been committed to them since 2016. And so this concert was actually a means to get them up on stage, to be able to perform. And we use that as a goal. It's actually used as an incentive to get them to work on their rehab goals, so that while they were in their center and they were working on their speech impairments, trying to overcome some of the barriers they were facing with their speech, we got them to actually train and practice like a choir. We treated them like a real choir. And then we got them to work towards performing on stage. And if we put them on the UPM stage, and it's a big hall, grand hall, this hall alone could sit about 1,500 people. It made them really feel like, they are doing something, they're achieving something. And we realized that was so important for their preservation of personhood and for their sense of self-confidence. They wanted to do it. In fact, this gentleman here in the red shirt, in another event that we held, which we got them to perform, he was actually not allowed to drive because obviously he has a disability, and with Parkinson's disease, there are a lot of mobility issues. But he was so anxious about getting to the venue, which was quite a distance from his house. He actually got in the car himself and drove all the way to the concert venue. And then his family panicked because the son was supposed to fetch him to the venue. And suddenly he turned up and we were like, okay, we're so happy to see you, but how did you come? And then he said, oh, I drove here. And we nearly freaked out because he was so worried about what could have happened on the road. But he, you could see, was feeling so excited. He wanted to be part of the performance, but he wanted to be able to be in a group. And I think we sometimes underestimate that, because we don't realize that even though people have disabilities, they have been impaired, perhaps because of illness, it doesn't mean that they don't want to be part of the community. And so we use music as an excuse. We create these concert platforms. We put all of them on stage. But what is also beautiful is that we empower them through music to encourage them to express what is important for them. So you will notice down here on the left-hand corner, it's the same Parkinson's group, and there's more of them. And they're trying to wave their hands as part of the choreography. We purposely inject that in because it helps them to work on their movement goals as well. But you can see that the way they are moving their limbs, that is not perfect, right? And it doesn't matter. Perfection is not what we're looking for. We want to engage them in participation and encourage them to put in the effort to work on their movement goals and to be a part of the group. And one thing that is distinctive about Parkinson's disease is that with Parkinson's, because of their obvious speech impairment, their voices go softer over time, and eventually they can hardly be heard. They can speak very, very minimally, and sometimes they sound like a whisper. So it's very, very frustrating because their voice is their personal identity. The voice is part of who they are. And once they start losing their voice, it's as if they're losing a part of themselves. So we're using singing, we're using this choir format as a way to gather strengths by putting them in a crowd. Because if they sound quiet individually, the moment you put them in a group and they're singing as a group, automatically they sound louder. So it does a lot for their self-confidence. And the strength is numbers also is a very powerful impact, because when people see how difficult it is for these Parkinson's patients to actually gather together on stage and then to sing, and yet they're there doing it, and they're often singing songs again with themes that are reflecting their own personal message to the community. We did a songwriting exercise with this group because we were trying to assess their coping, and we're using music therapy to see how to support their coping needs. And we ended up writing a song which was their message to the community. And the title of the song is Together We Conquer Parkinson's. And what they wanted was to be able to tell the community, we need you, we need your support. There are many more people like us out there, and we want to work with the community because that's the only way that we can get through this. So it's really, really powerful. You can imagine when we were doing this songwriting exercise, my student and I, because it was the final year project, we were all crying because we were so touched by the effort they put. These people struggle with issues of speech, and yet they are so painstaking and so committed to crafting the words of the song. So we hold these things very, very dear to us. The top picture here is my elderly choir, and so they do not have any severe illness or profound disability. But you can see it's really special because they're all in Indian costume. And what happened was, for this group, I was asking them what does choir mean to them and what are songs that are important at their stage in life. And they said that they actually wanted to spread a message of multiculturalism in Malaysia. Because at that time in Malaysia, we sometimes have racial tensions and we have differences between racial groups. And so they come from a generation where they grew up with more mixing between the races. And so they want to promote the message of multiculturalism and how important it is and why we shouldn't take it for granted. Such a powerful message, right? That was their mission, that was their idea. So what I do is I use music as a way to materialize their values. And this particular song that they sang when they were wearing these costumes, all their idea, they wanted to dress in Indian traditional costumes. And we actually sang Jai Ho from Slumdog Millionaire. I'm sure you're very familiar. A.R. Rahman. I'm an A.R. Rahman fan. And so they sang the song. They learned how to speak and sing in Hindi, and it's a fast song, which is not easy because you can see most of them are all Chinese and nobody knows and understands Hindi. But one of the ladies in the choir was actually from a Hindu background. So it became an opportunity for me to then put her in front of the group and say, you be the expert. I unfortunately don't know Hindi, but she does. You can teach the rest of your friends. And they took so much trouble to master the song. So it was so joyful to see that kind of experience and how just having that supportive group and being given the outlet to express themselves actually helped them to come to life. And people still talk about their performance until today. I'm very, very touched by that. And this girl who is on the right hand lower corner, she's actually one of our graduate students. She's just about to start her PhD. And she actually is working with a breast cancer survivors choir. And she actually has initiated several community choirs. Her PhD topic is going to be looking at choir and how it supports mental health. So I'm very, very happy to see all this work being done, revolving around creating inclusion. So I hope that is a vivid demonstration for you. I'm just going to, sorry, it actually came out of the full screen mode. Let me go back. So this is a different event that also involved inclusion, but it's not a event that was hospital-based. It was actually something where we had an international exchange between Japanese marimba players, as you can see, and there was a Down syndrome child who was one of the members of this marimba orchestra, and my elderly group, and we performed the song together. But what is significant about it is, remember we talked about how as part of the biopsychosocial model, we also take into account environmental factors. So this was designed as a sensory-friendly concert. And so we designed the whole hall to have the kind of experience where people who had special needs children who usually are worried about how can children possibly sit through a long concert. And, it's very common if you're working with special needs children, they may vocalize, they may gesticulate, they may walk up and down. It's harder for them to control their impulses. So we purposely created this sensory-friendly concert to allow them to be themselves and not to feel stigmatized. And we made it clear that everyone was welcome. And if they needed to bring their comfort toys, they needed to bring headphones because some of them cannot stand loud noises, that was perfectly acceptable. And we did this right before the pandemic, and we collected responses from the audience that was there. So there was also a little bit of research involved. And it was overwhelmingly positive, not just for the performers, but also for the audience. And so we know that it is possible for us to use music to create these inclusive spaces on many levels. And music can transcend the actual environmental space. So looking at all that, and those were a series of examples I wanted to share with you so that you can see how the theory is actually being put into practice. So what are the advantages of the biopsychosocial approach as a whole? So first of all, we know now that a patient's subjective experience is as important as their objective biomedical data. So we acknowledge that and we put in the effort to make sure that we use music as a means and a platform to provide that support on a psychosocial level. It's also useful as a model of causation that is more comprehensive and naturalistic. Remember, I showed you that simple diagram from point A to point C, right? That would be a simple linear reductionist model, but that doesn't really mirror the real world. So the biopsychosocial model allows us to more comprehensively and more realistically reflect what is happening in the real world and to create models that mimic real world factors. It also provides a perspective on the patient-clinician relationship that gives more power to the patient in the clinical process. Remember, I mentioned how it was so important to give patients a sense of control when they were in the hospital environment, that they are allowed and encouraged to make choices, safe choices, and also to transform the patient's role from being a passive one, just receiving instruction and following what the doctor or the medical team says or the family is telling them to do, but also to encourage patients to become a main catalyst in spurring forward their treatment outcomes. So this is all about promoting patient empowerment through these four main phases. And this is part of the biopsychosocial model: patient enablement, activation, engagement, and also to have patient involvement. That's the last one. So these are the three government hospitals on the left that I'm currently operating in. There's going to be a fourth one, but we are providing medical music therapy support through UPM. And what we found is that by incorporating and adapting this biopsychosocial model, we were actually able to provide support through medical music therapy by helping to develop that self-awareness, active cultivation of trust, an emotional style characterized by empathy, curiosity. I find this is a two-way process. When we seek to be understanding with patients and we seek to really honor their experiences and we take the trouble to find out what is it like for them, they actually reciprocate. So the cultivation of trust and the display of empathy works both ways, and they're more receptive. They're more willing to listen. So if we are telling them certain things about personal factors, maybe they have to think about making some personal changes, they're more likely to be willing to listen because trust and empathy has already been built. Self-calibration as a way to reduce bias. So there's a lot of self-monitoring that's part of self-awareness as well. Educating the emotions to assist with diagnosis and forming therapeutic relationships. So sometimes, and the research shows that what often undermines patients in these kind of treatment settings, or even when we are going through challenges, is not necessarily our thoughts. It's usually our emotions that are uncontrolled. And learning how to regulate, learning how to manage, and by manage, I don't mean suppress. I mean manage as in to learn to acknowledge, to understand what your emotions represent, and then how do we deal with the emotions so that our responses can be functional. So all that is extremely crucial because sometimes it's normal that people feel angry. It's normal that they feel resistant or they're in denial. But if that emotions are not regulated and somehow transformed into a more productive response or a more functional response, it can actually be a barrier to treatment. So they will not be able to fully participate. The forming of therapeutic relationships is absolutely essential to develop that basic trust. So they're more willing to listen and to cooperate, and also to use informed intuition. And we have to use music as a means to develop the kind of dialogue that enables the patient to give their input. So again, going back to patient empowerment, and it's not just a mechanical application of protocol. So the salutogenic model is something that we embrace. And of course, I know very well that ISCM are experts in this area. And so we talk about this conceptual framework, which Antonovsky came up with, that has also actually, interestingly, been supported by music psychologists. So I went and looked into the research, and I found that there are music psychologists who actually describe the need for us to be adopting more of a salutogenic approach, and that's creeping in more and more into music therapy. So I hope that also is another point that we're resonating with. And what McDonald, Kreutz, and Michel, who are music psychologists from the UK, indicated was that every individual can activate their intrinsic or inner personal psychological resources that help them to cope with illness without relying exclusively on external support to overcome health problems. So what is really, really nice about the salutogenic model, it is an extension of that patient empowerment piece. And we're talking about trying to identify factors of internal resources, intrinsic personal psychological resources that can help the patient to better cope with illness and not to be so dependent on the external environment or other people. So in this way, the view that health is to some extent in our own hands, rather than being granted from any health system around us, also means that health practices are rooted in everyday activities, and many of those are related to the arts and culture. In fact, this is very much the essence of what the synergistic approach to health and well-being is. It is focusing on the protective and preventative aspects. And when we talk about using resources that are in arts and culture, we are talking about how there may be everyday experiences in which we are able to participate in arts activities, whether outside the hospital or even bringing those art activities and cultural activities into the medical and healthcare settings. I think that is so important to help patients to remain grounded and connected to their cultural connections, especially if you know that that is a source of strength for them. I've dealt with patients who spiritual coping is extremely important, and there's a whole area of research about spiritual coping. I know that India is a very spiritual country. And so if there are elements of Carnatic music, ragas, that you find have that spiritual component that speak to the patient and help the patient to cope, then obviously I know that you're already doing some wonderful work in that. And I'm sure that those cultural aspects become a major source of strength and support as part of the therapeutic process. So we know that salutogenesis emphasizes that all human beings have that internal or innate capacity to move forward towards health, even in the face of hardship. And when we're dealing with patients who are stuck in hospital and they're going through a difficult recovery process, anything that moves them forward and helps them to see the potential for recovery, even if it's not a full recovery, but it may only be a partial recovery, best case scenario, it is still meaningful. It is still something that can vastly improve their quality of life and promote their independence. So today, the term well-being has also become an integral part of health. And what matters not is how poorly we feel, but how well we can feel and the cultural resources available to sustain and develop a sense of coherence. So I really like this model because it's actually a version of the synergistic model, which brings in culture. And I really hope that just looking at this and the way that it has been conceptualized and all the cultural stresses, cultural assets, give us a level of food for thought to think about the ways that we are mobilizing culture, adapting resources from culture right now into our own treatment context, and how that can bring in a level of psychosocial support. And we know that Antonovsky himself considered culture as important, and he included the role of culture in his writings about salutogenesis. And he actually included the role of culture in life, in shaping life situations, giving rise to stresses and resources, which is what you see under B and C in this diagram, contributing to life experiences of predictability, load balance, and meaningful roles, facilitating the development of the sense of coherence, and shaping perceptions about health and well-being. So culture is implicated on all those levels. And that was actually the thinking of Antonovsky himself. So Antonovsky's writings, of course, were sometimes conjectural because his opinions and conclusions were formed on the basis of his personal experience, but they still provide us with a valuable insight into the role of culture. And it helps us to recognize that culture is an integral aspect of the synergistic model of health. Now, launching off from that, there is another health model called health musicking, which I think would be very relevant for Indian context. And that's the reason why I'm introducing it now, because we have the biopsychosocial model, but the health musicking model presents us with a slightly different perspective, which I think is also extremely helpful to bring in more of that psychosocial support. So music, health, and well-being is a broad field. We know that it encompasses many different areas. But health musicking itself is actually derived from Christopher Small's original musicking model. And according to the model, the therapeutic impact of music is derived primarily from musical engagement. which is the levels of relationship with music and between music and the person. So when you apply Small's theory to the health musicking model, music is something that you do and you participate in to derive its therapeutic benefits. So what I would like you to just very briefly look at, because you can find out more about the health musicking models. There is research articles available. You can just do a Google search. But it focuses on 4 major goals: the development of communities and values through musicking, which is perfect for fostering psychosocial support, shaping and sharing our musical environments. Already from the biopsychosocial model, we saw how environmental factors are also important as part of the biopsychosocial model. Professional use of musicking and sounding to help individuals, as well as the formation and development of identity through musicking. So there are many, many aspects that overlap with psychosocial factors. This diagram gives you an overview of what the health musicking model looks like. And it is a quadrant model, and it shows how health musicking relates to those 4 major purposes or goals, which I showed you before. I encourage you to go more deeply in the article if you're interested. I'm just breaking up the quadrants to show you what happens within each quadrant, but I'm also aware that we are running out of time. So I would like at this stage to perhaps stop here, and I encourage you to go away and to look at this model on your own so that you can appreciate what the potential is in the health music model to provide psychosocial support to your patients and your community. And of course, if you have any questions, please feel free to ask me. I'm so sorry, Danita, I can't hear you. Don't worry, these technical things happen. Fully understand.
Can you hear me?
I can, but it's quite soft. Let me try.
Yes, the forum is now open for discussion. Thank you so much, ma'am, for that wonderful presentation.
My pleasure.
The participants can go ahead and ask their questions. We'll pass on the mic. So ma'am will be answering the questions for the viewers.
One mic is
Not only questions, any thoughts, feedback, anything you want.
Thank you so much, Dr. Indra, for that amazing presentation and talks. I was watching it on YouTube, where we have a big live for others to benefit from this talk also. And it felt like you were here. So even though your physical presence is not here, it's as close to it. You have given amazing perspective there. And I would like to thank you. I think a very big round of applause for our beautiful. And as you said, the cultural aspects of wellness. I think this is the strength of Asia. We have a very strong cultural basis, and this cultural basis we often are neglecting it because we think that we need an external validation. This is one of the problems we have in our country, that we want an external validation. And so we are not able to have what is called as Swabhiman or self-esteem. Suya Maryada is what they call it, but it has another connotation in this part of the world. About our own culture and its impact on the biopsychosocial, and I will add spiritual model. There's a new component there, biopsychosocial spiritual model. And I think, we forget that our culture has so much to offer the multi-dimensional aspect of human being. So your sharing of the experience in Malaysia, which is not too different culturally from this part of the world. We forget that there's a lot of similarity in the whole of Southeast Asia, lot of similarity of culture, and tapping into our own culture as a health resource. I think this is something that I feel would be wonderful, and that is why we also have with us our dear Mahesh Vinayakaram today. You can show the camera on that side, so ma'am can also meet him. Who is with us. Can we have a rose to welcome? One second, please. So, a pleasure for us to welcome. So, welcoming our dear Mahesh Vinayak Ramji and Mr. Kirtan, a very prolific musician, amazing musician, and you are going to experience his session this afternoon. And the very amazing son of a very amazing legendary father. His father is Bhikkhu Vinayak who, as you know, is a name across the world in multi aspects of collaboration with so many musical geniuses. And such a pleasure to have Mahesh Ji with us. So I wanted to introduce so that Indra Selvarajah in Malaysia. I was going to be in person. I would have had you all line up together, but still we are lining up. Thank you, sir. And he is going to be giving us an experience of that spiritual component. So what we talk about the psychosocial and that spiritual, because spiritual is always a big question. What does it mean? How do you experience it? How do you find it? How do you share it? And I think this is just wonderful, ma'am. I wanted to congratulate you on your presentation and open it up to any questions from our audience. You must ask questions, okay? That is the way forward. Put your hand up first. Otherwise, I will put your hands up. Okay. Yes.
Thank you so much, Dr. Ananda, for that very, very generous and very important contribution.
Namaste, Dr. Indra. So wonderful to hear you, your work. Truly appreciate all that you have been speaking about. I know it is like more experiential, practically done, and then you are speaking out of your heart. It is not just theory out of a book. So truly appreciate all that, especially the psychosocial support being offered to the special population, which is something, I don't know, maybe in future, that is something we need to expand on and, bring them out and support them, bring them into this wellness factor and take it forward. What is that? Health musicking. That was something very, very interesting where you showed it as a 4-quadrant, structure. So we have something in health, which is again a 4-quadrant structure. So is there something similar is what I would like to know, because you just rushed through. Like upper right, left, and then I wasn't able to observe what was there in those quadrants. If you can quickly give me a glimpse of just what is there in each quadrant. And that may be something, a model which we can think about adapting with your support and help, of course.
Sure, of course. Thank you so much for your interest in the model. I will do a screen share so it's easier for you to see what those quadrants look like. Just give me a moment. So basically, the quadrants represent 4 different areas located within the health musicking model. And I mentioned that they are aligned to 4 purposes and goals. So the first purpose is the development of communities, values through musicking, and that represents the upper right quadrant. And here we're talking about the creation of musical meaning within a social space. And this can be a family, institution, local community. However we develop the meaning, it is negotiated by the person's musicking. And what the musicking principle means is that everybody who is involved in the music process, it doesn't matter whether they're the performer, the composer, or whether they're the patient, or even people who are serving behind the scenes. Everybody who is part of that music making experience has a responsibility and a role to play. And so the development of musical meaning is cutting across all these different needs in the group And activities are facilitated by community musicians or music therapists. And what I really like about the musicking model is it's very, very supportive of people who come from a range of backgrounds, including those who are not musically trained. So you talk about how in the general public, we sometimes may have people with zero knowledge of music. And we've encountered in Malaysia, sometimes people are inhibited and afraid of being involved because they are very, very conscious about the fact that they may not have any music knowledge. They don't consider themselves musicians. They're worried that they will sing off key and they can't hold a tune. But the health musicking model is inclusive. So just now going back to the biopsychosocial model and mentioning about the importance of inclusion, this is actually well supported by the health musicking model as well. And it allows people to explore their potential to be able to make changes through the musical experience that they share and create meaning, whether individually or together as a group. And so these can be emotional, relational, affirmative, or corrective. And going back to what I mentioned just now about the adverse childhood events, and how emotions play a role in undermining patients' recovery process, we actually find that the health musicking model at the heart of it, if you go back to, let me just go back to this main model, right at the center is this affirmative, corrective, emotional, and relationship experiences. So we are talking about how all the 4 quadrants ultimately converge at the center. And so I really like the way that we are looking at a model for promoting health and well-being through music that is not only accounting for the fact that in society we have people of very diverse and different backgrounds, including people with special needs. And you're absolutely right in saying that we need to bring people who have these disabilities, children with disabilities, to feel that they are part of society and they're not excluded. And the health musicking model supports that. If you look at the lower right quadrant of the model, it is looking at the shaping and sharing of musical environments. This is something I find is very, very good as an addition to what we do in music therapy. I mentioned just now environmental music therapy, which is something new that is slowly growing in popularity. But relatively, when we talk about environmental aspects of music making, of the experience, we sometimes overlook things like the potential and the presence of damaging noise. And also sometimes I mentioned in a hospital settings, especially, you get a lot of noise from the equipment, machinery, the alarms, the beeps. I work with premature infants as well when I was training in the US, and we know that they're easily startled. And sometimes just having so many of these machines going off can create this shock reflex that they have. So we are trying to find ways to improve the sound environment for the patient so they get better quality of sleep, so that they are less distressed and they are actually in a more relaxed state, which we know is all better for their medical treatment outcomes. So this particular quadrant is talking about how we can shape the environment and give consideration to the fact that we are also incorporating the public space and how it impacts the body and the personal experience of patients. So in this quadrant, they talk about specially designed health promoting soundscapes. They're doing a lot of work in the UK, looking at how they can actually modify hospital environments by changing the soundscape. We also have heard of cases where they're using soundscape in nursing homes to preserve memory, especially for dementia patients. And this is something that really blew my mind when I first read about it in the research, that because dementia patients are slowly losing their memories, we know that they're losing their sense of self-identity, and it's really tragic. But what we sometimes don't realize, when they lose their memories, they also lose their ability to recognize sounds in their environment. And that is potentially something that only increases and elevates their anxiety and their tendency to go towards depression. And the reason is, can you imagine, there's so many cues that we receive through the sounds that we hear in that environment that tell us about where we are, our position, our placement, safety. If we hear a dog barking, we know it's a dog. When we hear the thunder, a rumbling, we know that a storm is coming, potentially to go and seek shelter because maybe there's going to be rain. But what happens if you forget what those sounds represent, you can imagine how scary it can be for the dementia patient. So they hear a dog growling and they have absolutely no idea what that sound is. So they are terrified to go out, because the moment they leave the safety of their home and they walk out into the public space, there's going to be traffic, there's going to be the roads, people, vehicles, and they can't recognize the sounds. So I really find it powerful that they are actually now using soundscapes and promoting soundscape in health settings. And so they are talking about, on one hand, limiting the potential of damaging effects of noise, negative sounds in the environment, but at the same time, they're also trying to increase sounds of comfort and beauty to the community. And I found that the research, going back to dementia patients, also shows that they respond very positively to sounds of nature. So they hear bird song, they hear the sound of water, of waves. Those are positive sounds of comfort and potentially of beauty. I would imagine that culturally, there are so many sounds that belong in your environment that also, whether it's temple festivals, when you hear the bell. I remember for my own father, 1 week before he died, he was telling us that he found a lot of comfort just hearing the temple bell, because he's Hindu. And so every time we took him to the hospital, to the temple, and he hears that temple bell, that actually gave him a sense of peace, and he felt safe in that environment. So sometimes, that's a very personal sharing, but that is, I think, a very vivid reminder of how much even the sounds of festivals, sounds that are part of our religious rituals and culture, are also really important for comfort and for spiritual edification. The third quadrant, which is the lower left quadrant, is what they talk about as professional use of musicking, sounding to help individuals. And here we are talking about professional knowledge of psychophysiological effects of sound and music interventions to inform clinical practice that are meant to promote health of the individual patient or client. So music medicine, there is another area that is slightly different from medical music therapy. And music medicine uses a lot of recorded music, and it can be administered by people who are non-music therapists. Sometimes it's nurses. We look in the literature. A lot of music medicine also involves the primary initiative of medical staff. But it also means using specially selected music for sound and music healing processes to promote relaxation, playlists that can be adapted to needs and preferences of individuals. So sometimes in music medicine studies, you notice that they have pre-recorded listening lists, playlists, where they compile the patient's favorite music. And in that way, it can be a source of personal comfort, especially if they're listening to it through a personal listening device. On the other hand, we have to be careful that that sound level is not too loud, because it can also contribute towards hearing loss. On the other hand, in music therapy, we use music listening, playing, improvisation as a means to regulate pain, arousal, and so forth. So this is talking more about the professional uses of music, whether as a medical music therapist or through music medicine for healing purposes. And the last quadrant talks about formation, development of identity through musicking. I think this is a very, very strong social component to it. And it also strengthens our sense of personal identity, preservation of personhood. I used the term just now, and it's so important, especially when people are affected by a disease that is robbing them so much of their identity, of their sense of self. If we can use music as a way to strengthen the sense of their personhood, I think that's a really, really powerful thing. That's what we try to do for our Parkinson's patients, so that we are seeing the person beyond the disability, beyond the illness, and we try to honor that. And I think that has actually been one of the more successful outcomes of the interaction that we share, because they know that when we look at them, we don't just see Parkinson's patient, we see people first who happen to have Parkinson's. So the disease does not define them. So in this particular quadrant, we're talking about musicking to facilitate performance of the self's ability to respond and to be able to perform in different contexts. And you can use music listening that is designed by professionals, such as music therapists, to support communication expressivity, so give them outlets for self-expression. It can also contribute to confirmation development of musical identity in ways to lead to the formation of musical communities in persons with different health problems. So this is where you can form a support group, literally, that helps to reinforce the sense of personal identity as well as group identity. And I think that is actually something which I found when we get to do that, it can really, really indirectly turn into a support group for the patients that then will continue to live on and continue to be a source of strength even beyond the music therapy session. I hope that helps.
Thank you so much, Dr. Indra. That was beautiful. You have actually, triggered something, some interest within us, and we are going to explore more on that, and we'll definitely take your inputs. You are anyway with us, so we'll certainly explore more on this and see how we can implement it in our music medicine fields. Thank you so much.
Thank you for your wonderful questions. I really, really appreciate your interest.
Does anyone else have a question or a thought you want to share?
Greetings, ma'am. I'm Ankit. I'm a medical music therapy, third semester student at ISCM. So, firstly, it was one of the best presentations that I've seen. And the thing that we talked about Indra also said that how social aspects as well as cultural aspects in the continent, in the Southeast Asia, is a strength that we have and how we incorporate it in music therapy. But my question is regarding how you see the cultural and social aspect as a limitation. And if you see it as a limitation in some ways, then how can address it and overcome it? That's what the question I want.
I think that's a really, really good question. And I really appreciate you asking it. I think one of the things that is common, and we experience this in Malaysia as well, that is why I put up that slide after we talked about the disability model, is social stigma. And we have a lot of cultural stigma around disability, around certain illnesses. And it's very heartbreaking to see that when you have patients or individuals with special needs who are already struggling because of the disease, because of their condition, on top of that, they have to deal with society's negative attitudes towards them. And I find that if you look into, there's a very, very good UNICEF report that talks about the status of children with disabilities. They have country reports, so I read the one on Malaysia, but I'm sure they also have one in India, because they do this for all countries. And they mention how sometimes environmental barriers, cultural barriers act as the bigger injustice and the thing that really holds back people with disabilities. So I think, apart from cultural stigma in a very general sense, which unfortunately stems from perhaps ignorance passed down through the generations, a lack of familiarity, we are dealing with that all the time in Malaysia as well. I think education, awareness is such an important way to counteract that kind of cultural stigma. I also want to bring up the fact that, remember the Seleucid model of health that I shared with you, and let me quickly do a share screen. I love that diagram because they have actually identified the cultural stresses. And if you look at this slide, they talk about cultural assets, so all the strengths that can come from culture, from cultural stability, cultural equipment, and so forth, 6 items. But look at what they have outlined here as cultural stresses: minority backgrounds, gap between goals and means to achieve goals, rapid change in culture, cultural discrimination, complex culture, hostile culture. So that is hinting at the fact that these negative stresses also exist in culture. So the combination of the stresses and what I mentioned is a big deal, cultural stigma, and we are constantly dealing with that problem in Malaysia. I would say those were the 2 main important references. I hope it's helpful to you. Thank you so much for asking such an important question.
Thank you, Dr. Indra. Do you have any more questions?
There's somebody who wants to. Let's check if the mic is on. Good morning, ma'am. So I'm Akshaya. Have you used music therapy or music medicine among psychological disorders or anything as such in that aspect?
I'm so sorry. I can't hear properly. Do you mind maybe speaking a bit louder? I'm so sorry. Technical issue.
Are you able to hear me now?
A bit better.
So have you used music therapy or medicine in psychological disorders or anything in that spectrum?
Yes, thank you so much for asking that question. I belong to a local organization called the Malaysian Society for Music and Medicine, and we frequently collaborate with the Malaysian Mental Health Association. And we've done joint projects where we try to reach out to the community, especially because after the pandemic, we found there was an increased escalation of depression. We have a lot of mental health disorders that have actually exploded following the pandemic. So we've been using music therapy on different levels. I personally been involved in projects where we are talking about using music to either increase coping skills or helping, even with the example that I shared with you with the song lyric analysis, that is often used even with music and counseling. So when we are trying to get patients who are struggling with mental health issues to process what they're going through, that is one of the tools, the go-to techniques that we use. But I think usually what is recommended here in Malaysia is a combination of medication and talk therapy. Of course, if there is a more serious mental disorder, then you have to see a psychiatrist as well. But yes, music therapy is widely used in all those areas. I've been involved in some of the work. I think if you're really interested in that area, there is this American music therapist by the name of Michael Silverman. He has written extensively on the topic. So I really encourage you to go and Google search and look up his articles. His name is Michael Silverman, and he has researched extensively about music therapy and mental health. Thank you so much for the question. I hope my answer helps.
Thank you very much. Okay, so then we have more questions. Yes.
Namaste, Indra ji. That was a fantastic presentation. Though I could not be there for whole of the session, I was happy to join on the last 20 minutes of session. All of your answers are completely with the hashtags. It's just all your answers are coming with all lovely knowledge, and it's been a honor and so good to see. And I just wanted to really congratulate and also wish you good luck to continue this beautiful thing what you're contributing to the world of music therapy. Thank you.
Thank you so much. Your words really, really touched me and encouraged me to push forward to do more. I really appreciate it. Such a pleasure to have you in the session.
Thank you very much, sir. Then we can now we have to go on to the next session. So we'll take a short break. Thank you so much, Dr. Indra, for making your time today and really miss your presence. Hopefully we have it taking place some other time. So we take a 5-minute break and we join for the next session. Dr. Indra, you can stay on for the next session as well. If you have the time permits. Thank you very much. On mute, Dr. Indra.
I really want to say a heartfelt thanks to you, Bhuvana, and to Dr. Ananda for making it possible for me to contribute the session. I really regret not being able to be there in India due to unfortunate circumstances, but I'm so happy that at least with whatever way I'm able to communicate, my spirit is with you. And it has been my absolute pleasure to be involved in your fantastic initiative. And I look forward to being able to continue to collaborate and to see how we can continue working together so that I can hopefully bring more benefits of music therapy to support the work in India. It's a beautiful country, and I've grown to really, really appreciate the people. Thank you.
Wait for 5 minutes. And we can assemble back here.